and welcome everyone. My name is Dr. Kelly Volz, Senior Manager of Professional and Clinical Affairs at CooperVision Specialty Eye Care. Today we are joined by Dr. Nick Despotidis, a pioneer in the use of orthokeratology lenses. His TED Talk, A Childhood Disease Worth Preventing, has been translated into 6 languages. Dr. Despotidis graduated with honors from the State College of Optometry in New York and later completed a residency in vision therapy and pediatric vision. He has published papers in optometric journals and is a frequent lecturer. He is also the lead author of the book, A Parent's Guide to Raising Children with Healthy Vision. Dr. Despotidis is a fellow of the American Academy of Optometry, American Academy of Orthokeratology and Myopia Control, and is a board-certified fellow in vision therapy with the College of Optometrists in Vision Development. Welcome, Dr. D. We're so excited to have you today.
Thank you so much, Kelly, and I'm glad to be here. So I wanted to welcome everyone. I know many of us are burnt out with virtual webinars, and I would love to do this live, but until that time comes, I welcome the opportunity for you guys to look inside my office and hopefully learn a few tips so you can incorporate them in your practice starting tomorrow. So to start, I'm just going to let you look inside my office a little bit. We opened cold 30 plus years ago. Our neighborhood, our community is middle. It's not upper class, not lower class. It's a very hard-working class that we've prospered. We only have one location, and we have a multidisciplinary practice. We enjoy it. I have several partners. One partner, Barry Tannen, he runs our vision therapy clinic. My other partner, Ivan Lee, he runs our medical optometry clinic and primary care. I run the Ortho-K or CRT aspect of our practice. And Dr. Noah, our latest partner, really shares in all of them right now as he gains his foothold in our practice. And I think it's important for many of us to realize my life, my practice is a lifestyle practice. And I picked this term up by a TV show where entrepreneurs introduce themselves and they try to sell their business to these very successful and wealthy entrepreneurs. And what they are looking at is growth companies that you build and sell. And that's something that's very common right now in optometry, is the hopes of one day growing your office and selling it. And it's happening quite often right now. What we've managed to do over the past 3 decades or more is really build a practice where we have no intention of selling. It fulfills all our lifestyle, all our partners. If you interview us individually, they'll say, we really have no plans on retiring. We enjoy what we're doing. Financially, we're compensated for what we're doing. Yes, it's stressful at times, but you know what? We enjoy ourselves. We travel, we vacation. So we built a practice that furnishes our lives. And CRT was a key component to that growth. And that's what this talk is about. You know, we dropped insurance plans in 2001, so well over 20 years ago. And we see patients 3 days a week. So you can see we don't get burnt out. The other 4 days of the week, it's not like we're golfing. We're working on our practice. Maybe we're working on different things concerning our practice. But as far as seeing patients, almost all of us only see patients 3 days a week. So there's no burnout now. You know, when I graduated, again, almost 40 years ago, it's hard to believe, 35 years ago, you don't hear any burnout in my voice. We long ago transitioned from a commodity-based practice to a service-based practice. What does that mean? So about 2001, Barry and I were the only partners here, and we realized the majority of our income was based from eyeglasses and soft contacts, like 90%. That just left 10% for exams and specialty care like myopia control or management. We started back then orchestrating a practice that slowly but surely got us off that dependency. So we're very happy today. We don't depend on insurance plans to feed our practice. We depend on specialties like CRT that really has fortified our practice so we can withstand things like this past pandemic, and we'll talk about it. Some of the milestones concerning myopia management that I'm most proud of. Before 2002, I was dabbling in orthokeratology. Actually, my partner Barry brought it in 1992, 94, when the reverse curves became popular. But it was only when Paragon got FDA approval in 2002 that my practice really started to flourish concerning this subspecialty. Why? It wasn't only that I had an FDA-approved lens in my arsenal. I had a company behind me. I don't work for Paragon. I'm getting an honorarium for tonight, but they couldn't pay me if I did not believe in the company. Paragon supported my company in the early days when the other labs just didn't understand marketing. And I'm going to talk about the difference between marketing and advertising. And that's why we flourished. I wrote my first book in 2000 again with the help of Paragon. I remember them getting optometrists to read my book and write testimonials on the book. They helped me print the book, where I'm an optometrist. I'm just like many of you out there. I had no idea of how to get a book published, but I had a company behind me that supported me every step of the way. I did a TED Talk that I'm very proud of because I worked almost 10 years to get this talk in 2018. The title of the talk is A Childhood Disease Worth Preventing. And this was a game changer because I saw that the audience out there knew very little about myopia management, but even less about myopia. So even though I've lived this and breathed this every day, I realized parents have a concern concerning their children's use on electronic devices, subconsciously or consciously knowing that they're causing some side effect. And I was one of the first to say, yes, myopia may be a side effect of children always on their devices indoors. Concomitantly, I wrote my second book, again with the help of Paragon Vision Sciences. And then a milestone that I'd like to talk about, which we've all experienced, was 2 years ago, the pandemic. Before I begin, I want to show you a video that I stopped showing. About in 2008, I put on a Harry Potter premiere for my corneal reshaping patients, only them. And my wife is videotaping this. It's in front of a 24 multi-theater plex. And these are my patients and their parents, unbeknownst to me, online, waiting outside to get in. I had no idea this was going on, but I got away from viewing it. It is inspiring because it's so many years ago. And those are the number of patients wearing CRT and other Ortho-K designs. You could see the enormity of patients who needed myopia management back then. This was long before it was in vogue. All these patients are my patients with their parents waiting in line to get into a theater that premieres Harry Potter that I sponsored with Paragon's help. So when Paragon asked me to speak, I, of course, said, absolutely. This shows you the huge potential that myopia management, specifically CRT, has in your practice. So these are the practice milestones that my practice has persevered through. The first tip I have is myopia management is not for wimps. And that is a competitive edge. Private practice is not for wimps. And many of you listening to me tonight are definitely not that. But I want to tell you, it hasn't been a smooth ride. Barry and I, in the lower left-hand corner, opened up our practice in 1988 with the advice of Gary Gerber, who now owns Treehouse Odds. You could see the path that I've taken is we went up in 92, we went up more in 96, and then it says first major meltdown. So we did it. And anybody who's been in business will tell you, yes, Nick is being honest. Private practice is like any business. You're going to have ups and downs. And when we're going to talk a little bit about Paddy Lunn, who is 1999, this crazy dentist from Australia, and what he taught us. And then In 2001, when we dropped vision plans, when we closed on Saturdays, we took on my third partner, Ivan Lee, as a partner. We built a 9,000 square foot building. Concomitantly, anthrax happened in our community, and our business went to zero. And this helped me during the pandemic because I experienced something like this. Not to the extent that really lasted almost a year, but I was up and running a lot quicker than I did during this pandemic. And then we started growing. We didn't close our doors. In 2010, 2012, we established a private practice residency. We opened our second location. We closed our second location by 2012 because we realized we're a lifestyle business. We were making as much in our one practice net as we were in having two locations, and then we prospered. We started dropping health insurance plans. We no longer sell soft contact lenses. We know what our business is. Our business is specialty care. We took on our fourth partner, Dr. Noah Tannen, and we redid the interior of our building in between 2014 and 2019. And sure enough, we were growing until all of us experienced March 2020, when we were scared to death what this all meant. And I was one of them. But I've experienced this before. I knew this was going to be an opportunity for explosive growth if I could weather the storm. And sure enough, I'm happy to report in 2021, as far as myopia management is concerned, we broke all historical records and have been doing this for a very, very long time. So this tip is important because many of my colleagues, many of my friends will call me, hey, Nick, I hear you always lecturing on CRT or myopia control. I read about it all the time. They start dabbling on it. They fit a few cases. And just when the opportunity is there, when their experience is about to grow, when they have to make the difficult decisions maybe to drop insurances so they have enough room in their schedule to put these CRT patients in, they stop. They stop just short of gold. For us, gold is a really nice lifestyle. Like I said, all of us are most proud about always being able to attend our children's parties and events, going on vacation, having enough funds to buy nice cars that are reliable and new, nice homes. You know, it's just a nice lifestyle that our practice has helped us live. But it wouldn't be the case if I stayed with optical plans and even health plans. I feel the best tip you can get out of today is knowing the difference between myopia control and myopia management. And these are two terms that I've defined for myself, just for myself, because there's a distinct difference between controlling myopia and managing the family who is interested in myopia control as a corrective option for their child. So what do I mean? What is myopia control the way I define it? It's treatments designed to slow down the progression of myopia. So in the US, currently, we have 3 treatments, only one is FDA approved. We have diluted atropine eye drops at our disposal. We have multifocal contact lenses, my site being the first to be FDA approved for myopia control. And we have orthokeratology. And right now, as of this day, it's still not available in an FDA-controlled design. But we know from strong literature that it does seem to significantly slow down the progression of myopia in children. So what is myopia management? What's the difference, Nick? Well, myopia management is managing the family interested in myopia control. If you can understand this by the end of tonight's webinar, you'll be so far ahead of the majority of clinicians. Just because there's an epidemic of myopia, which we're all made aware of, doesn't mean every family will be interested in controlling their children's myopia. And the example I use is there's an obesity epidemic, forget about childhood. And we know that it's occurring in the United States. We're all made aware of it. But you would be hard-pressed to say every parent is concerned about it to the point of doing something about it for their child. I find that very similar to CRT. CRT is not a contact lens fit. If you squeeze your CRT patients into your schedule, you're going to fail. It just can't be done. And hopefully I'll be able to articulate this to you properly before the end of the evening. Before I talk about how to market a CRT practice, Kelly, are there any questions that have come up to this point? Have I made myself clear the difference between myopia management and myopia control?
Yeah, thanks, Dr. D. I'd love to address it from an FDA point because I think historically myopia control and myopia management are used interchangeably. But now actually we have from the FDA a very clear distinction between these two terms. So when we think about myopia control from the FDA's perspective, that really carries with it an indication to slow the progression of myopia. And CooperVision has the only myopia control medical device currently in the US market. So from the FDA's standpoint, they consider myopia control the ability to slow the progression of myopia in age-appropriate children. And so MiSight One Day soft contact lenses are specifically designed and are FDA approved to slow the progression of myopia in children from ages 8 to 12. The FDA's perspective of myopia management is a little bit different than our perspective as practitioners. Myopia management from the FDA's perspective is that we are simply addressing myopia, and this is more of a holistic approach. So we think of soft contact lenses, Ortho-K, and spectacles as correcting refractive error. Paragon CRT was the first FDA-approved orthokeratology lens design in the US to correct myopia. And then, of course, we also have atropine, known for temporarily dilating the pupil and relaxing accommodation. And then we also have environmental factors, which I'm sure we'll get to later as well, about modifying outdoor time and near work. So myopia control, FDA kind of considers that in one category with studies that support the slowing of progression, and then myopia management as a holistic approach, which I think we carry into our practices.
Thank you. Thank you for making that distinction. I really appreciate it. For tonight's talk, I really want the listener, the viewer, to understand myopia management is knowing the demographic who's interested in myopia control as a corrective device for their children. So once you understand that, you'll also understand how I have grown my myopia control practice or myopia management practice. How to market myopia management. I think a key distinction is knowing marketing and advertising are not the same. Advertising is something I've done in the past, newspapers and television, direct mail, radio. The new thing is, search engine optimization and Facebook ads and Google optimization. We get solicited by all these companies that design websites that can get my name number one when someone maybe searches CRT, for example. That's not how we've grown our practice. Because if that ad worked, what is the patient going to do when they call your office? They're going to ask, how much is CRT? Does insurance cover it? Does it qualify for flexible spending account? Is it new? Is it safe? Is it permanent? And we've had ads, advertising that has worked, and it has driven my staff crazy. And in the lower right-hand corner, there's a little quote from my office manager. Anyone who thinks advertising is the way to go is nuts, because the person calling or responding to the ad is not qualified. They're not educated. Marketing works. I try to create raving fans or raving patients, and I do this with two separate understandings. Number one, I know the demographic who's interested in controlling myopia with CRT, and I'm going to elaborate on that. I understand it, and I know how to market to them. And number two is, I understand what critical non-essentials are. I learned this from Patty Lund, the Australian dentist. Critical non-essentials are essential things to your practice growth that are not essential to a very good eye examination. So for example, a critical essential will be your 21-point exam. Tonometry, refraction, ophthalmoscopy, those are critical essentials. My practice, in addition to doing those critical essentials, do critical non-essentials that create raving patients or parents. I know my demographic. Maybe I learned this when I was practicing VT. CRT, the demographic comes to me from friends and family. So that Harry Potter video that you observed, the reason I did that is because it's goodwill. I'm repaying all my patients for their loyalty through the years. I made my practice worthy of discussion. So I know that parents who are extremely happy with my care, essentials and non-essentials, will talk about me on social media. Vision therapy is very different. Our demographic there are not the patients we serve as much as the OTs, the MDs that refer to us, the physical therapists, the teachers, the ODs, the coaches. Of course, we have to do extraordinary vision therapy. That's a critical essential. It's just like saying, I need to fit the Ortho-K lens just right. That's essential. What I'm about to discuss is the non-essentials that really create raving fans. If I was to talk about scleral lenses and how I've grown a scleral lens design, it's unlikely that keratoconics are going to talk to other keratoconics. They may go on chat groups, but my experience is I have to go through a lot of specialty fits to get some momentum. My demographic to refer to my specialty contact lens patient practice is corneal specialists. And low vision would be retinal specialists. I think any OD understands this. So I'm trying not to be everything to everyone. I'm trying to be this great optometrist to a very select demographic. So how do I do this? I know the parent who is interested in myopia control as a form of vision correction is usually an overachiever, and their child is an overachiever. It's usually a nervous parent. It's usually a guilty parent. So many of the parents have had LASIK, so they feel guilty that they have had a vision improvement and permanent, and their child still wears glasses. Or they may know they gave it to their child genetically or environmentally because they're pushing their child into myopia. And that's what my TED Talk is about. I'm one of these overachiever parents. I'm a very nervous parent. I'm a guilty parent because even though my wife and I were not myopic until we were adults, both my children developed myopia at 7 years old. So intuitively, I understood I must have caused this either with genetics and or environment. And this demographic views myopia as a disease. They understand it. I don't have to bang my head and really educate them that high myopia comes with a plethora of potential visual loss diseases like retinal detachment, cataracts, glaucoma. So how do I get raving parents? How do I get other parents? So you just need one CRT patient, one pediatric patient, and then you exercise these critical non-essentials. So let me give you examples of these non-essentials. We text or email all our patients, all our myopia management patients all the time. Kelly will tell you she was here at one time. Before they come in, after they come in. Why? It's because they have a lot of questions. And even though I allow a solid 20 minutes to answer their questions, maybe their spouse wasn't there at the day of the visit. Maybe they thought of more questions. I want to make sure that I know what questions are coming into my office and what questions they have after they left my office. And we text or email them every time we see them. It's extraordinary. Why did I build this system? because I know my demographic wants to be kept up to date. They want to know that their children's eyes get worse. They want to know, is there any side effect from the pain they experienced the other day? They want to know how well their child is seeing. So that's why we do this. I place urgency on every response. I know this demographic because I'm one of them. If I email someone, I expect a response within hours. And when I get a response within minutes, I know this company, this proprietor is worthy of my business. So our staff is trained to respond with every correspondence with urgency. It's no longer good for a parent to call and leave a message and they'll get back to you in between patients. We can do that. We always did it. But the thing was, it wasn't good enough for us to create raving fans. It wasn't essential to good myopia management. No, but it was critical to creating parents who make our office seem great by talking to their friends. So when their friends call our office, they're already educated. They're not asking, is it safe? Their friends talk to them about it. They know how much it costs. They know insurance doesn't cover it. They know about how many visits. They know about the procedure. So do you see why there's a distinct difference between advertising and marketing CRT? The easiest way and the most effective way to get raving fans, raving parents, is to spend time with them. So you have to charge accordingly, and we'll talk about that. What the pandemic has helped my practice, my door, 2 years, just about 2 years after we closed them, is still locked. I can't believe it. But that has limited my schedule, and I spend more time now talking with parents. What has that done? That has grown my office. It's counterintuitive. I'm seeing less patients, spending more time with those patients, which in turn is getting my practice worthy of discussion. Just think about that. And I knew this somehow, and Barry knew it, my partner, 20 years ago when we dropped plans, because when you accept plans, you need to work on volume. All of us have seen inflation hit our families. Yet I venture to say, if you look at your EOBs, your explanation of benefits, none of your reimbursements have gone up, I would say. And number two, I would say they may have gone down the past year or two. And that's why it's a dropping knife, in my opinion, to stick with plans that don't reimburse you for the care that you want to provide. I speak to them at every follow-up visit, and I have a dedicated staff assigned to CRT and myopia management. Everybody's involved, my receptionist, everybody, the preliminary tester. But I have some key staff who can answer these questions intelligently the way I want it to be answered. So these are all critical non-essential. Are they critical essentials like a 21-point exam? No. And if you just stop by getting a good fitting CRT or dual axis lens, you're doing a great job. But I don't know if that's worthy of discussion between parents. So these are the 3 steps to success. So before I talk about this, Kelly, do you have any questions? Does anyone else have a question concerning critical non-essentials, the difference between essential things that we do in the room versus critical non-essentials?
Yeah, thanks, Dr. D. We did get a question come in actually referring to the referrals. So somebody asked, I'm a new practitioner interested in growing my myopia management practice. Did you reach out initially to these different providers? For example, did you reach out to education within schools or to primary care providers, pediatricians? How did you get started in building those relationships to thus build those referrals?
That's a great question. That is a great question. I did all that and it did not work. And that's how I learned. The demographic is a parent who views myopia as a disease. So the way I grew it is I physically lectured, Kelly, for 20 years to any parent group. I mean, La Leche League up, that was interested in vision and specifically myopia. Chinese schools, religious schools, any parent, private schools that can get a PTA together and listen to me, I would speak to them to get one qualified referral. Because once you get the parent, Kelly, who comes and experiences these critical non-essentials, they will mark it for you. They will go on Facebook or WeChat or Snapchat or Neighborhood, these apps that talk about where do I get an optometrist, who's really good in this area. They will advocate for you. So you need just one. Today, because of the pandemic, it's even easier. You can do virtual Facebook Live seminars. So throughout the entire pandemic, Kelly, all of us were lecturing on environment and myopia progression. Do blue light glasses really work? Why are so many children on screens right now, and is it hurting their eyes? And we would leave it on our Facebook page, and parents would be able to download it and disseminate that information. What it did is just like that Harry Potter. Parents said, wow, where every practitioner is going in the dark, this guy is standing out and saying, listen, we know your kids are at home. We know your kids are on this computer or screen 24/7. Here's our insight as eye doctors. So we didn't have thousands of people tune in. We had dozens, but you need only a few to create raving fans. So that was a great question. You're a new practitioner, do a Facebook Live. Does online learning, virtual learning, does cell phone possibly hurt your children's eyes? And then you could talk about blue light. You could talk about going outside 2 hours a day. You could talk about Ortho-K. You could talk whatever you want. But the key is you will differentiate yourself from your peers. And hopefully in the process, you'll get one parent who comes in and fits their child with CRT. And that's all you ever need is just one parent. Does that answer your question or the listener's question?
Yeah, I think probably a surprising answer, but one that's much appreciated. It's really word of mouth that can create the excitement around myopia management.
Yeah, it's an honest answer, Kelly. I do this every day. I'm not a speaker. I'm not a consultant. When we're done tomorrow, I do what all of us do, better one, better two, and I enjoy it. So this is my experience that sending these letters out, ODs and other possible referrals just don't work because they don't have the time to explain what CRT is. You do by lecturing to parents either virtually or in person. So what is the 3 steps to success? Could it be as simple as a consultation, application and removal class, and follow-up visits? And the answer is, in my experience, yes. It's simple, but it's not easy, as you'll find out. I learned long ago I need a consult to find if the patient is a candidate. Also, it helps me determine if this parent is really interested. When I used to song and dance about vision therapy, for example, it didn't work. I needed to set up a separate evaluation to really take the time to explain what are the different options out there to control myopia, find out which option is the best for their child, and also explain my treatment and how it may be different from someone else that's in the Paragon doctor locator. So I allow 1 hour. We educate parents before, during, and after the consult. In other words, we'll send them videos of my practice to kind of introduce them to my practice and know this topography, Kelly, was a big issue because I needed clean topographies to accurately fit children. And it was kind of startling. Remember, the child is an overachiever, usually nervous. They come in, we're wearing masks, we're wearing gloves. They have to call the office to get in. So now the pandemic has made us better by actually corresponding them beforehand. I actually do a virtual talk, a virtual parent conference before the consult. And what that helps me do is kind of tease out who's interested and who's not. I educate them because remember, the demographic who's interested in CRT to correct their child's vision, in my experience, is one that cannot be pressured, that needs time. That's the critical non-essential I give all my CRT patients. And that's why I have this practice that is solely built on orthokeratology. It's not the fitting, it's how I manage the family. We give snacks, understand your demographic. Just because a parent is interested in CRT for their child doesn't mean the child is interested in wearing CRT. Some of these children, as you'll see, are as young as 5, 7, 9 years old. They're happy with their glasses. They're not concerned about myopia progression like their parents. And when I train this, a lot of doctors will have these kind of impotent snacks or just kind of impotent gesture to have them snack. Me, I make a big deal. We have these COVID-free snacks that have 3 snacks in a bag. We staple the bag shut to make sure no one else has touched them. I make a point of telling the parent the technicians wear gloves when they're putting the snacks in the bag, and there's a mystery. There's kind of like an excitement around this bag. How many snacks does it have? What's in there? You know, and then the child, of course, even if they say no, thank you, because they're not silly. They know, hey, I take that snack, you're going to put that lens in my eye. So I really take the time to get the child feeling safe with my care. And afterwards, what I implemented long ago is I write a full report, because no matter how much time I spend with the patient, they have to understand that my practice is different than all the CRT and Ortho-K fitters in my community. When I started 20 years ago, I may have been one of the few. Maybe there was a dozen in my entire state. Now there is a dozen fitters within a 1 mile or 2 mile radius of my practice. So practitioners have to differentiate their office. So what do I do during the consultation? We discuss fees. And this is where it's counterintuitive. I have found over the past 20 plus years of fitting orthokeratology lenses, the more the doctor charges, the more successful they'll be. So we can't discuss fees, but we can test as a concept that the lowest price, and we'll talk about this in detail, doesn't allow you to provide these critical non-essentials. And if you don't provide these critical non-essentials, you haven't differentiated your practice other than price. And there will always be someone who's less, always. So my suggestion is you charge what you feel you're worth. Don't be afraid of not growing your practice like I was. Have faith. I have no reason to deceive you. Charge what you feel you're worth and provide the time. And I promise you, if you have perseverance, that's how we started this out, you will flourish. You'll do more than flourish. You'll flourish because you feel good that you're providing a specialty like no one else can. You'll feel good because you've built a strong foundation for your practice that's not based on coding and billing or selling commodities like glasses. And you got to decide early on who's going to present the fees. I stink at this. Some of my colleagues, you guys are amazing. You sit down and you can explain your fees. With me, I start stuttering. So I've learned I'm very good at providing these critical non-essentials. I text, I email, I have my office, I have systems and systems that patients feel they are the only patient I have. These are systems-based. But getting reimbursed for that time, I was very slow. My office manager, Lisa, my business manager, who we took her quote, said, Dr. D, this is early on, 2004. I remember I was so happy. I had a fitting set of CRT. I had a system now. I had a company behind me. And I was just spending hours doing it. And she wasn't upset with the time because I was learning. She was upset that I wasn't getting properly reimbursed. So you need someone like Lisa to say that our treatment starts at X. And it includes 1 year of visits, 6 months of visits, 2 years of visits. In our office, it's 2 years of visits because I could not properly wow my patient in a year, get them properly fit, and assure them that their myopia is somewhat stable with axial length and refraction and all that. It takes me time. Sometimes it takes me months just to get the child inserting and removing them without a lot of drama. Months! So how can I expect to complete this task in 2 years? So I made it 2 years. And I did that with my scleral program. And you know what? It worked just fine. I've changed the lens as often as needed to get the best vision. My program, when I'm all done and the fit is stable and they're ready for a backup pair, is included in their program. We tell patients this is not covered by health insurance or vision insurance. We don't accept it. It's not covered if we did. But a lot of parents use flexible spending accounts to reimburse themselves. So my consultation is about an hour. The technician who's tasked with presenting this to the parent, it could be another hour. So you need to make time. Remember, that's the critical non-essential. And parents always ask, is there a discount? And I used to say, yes, we had all these discounts. You pray early? Yes, there's a discount. Sibling in the program? Yes, there's a discount. You pay at the time of the appointment, cash? Yes, there's a discount. Will you delay my billing? In other words, would you change the receipt because I didn't put so much funds in my flex spending account? I didn't know it would be that much. I'll pay you now and change the receipt. I never said yes to that. And my staff said no. Let me tell you, all those things only hurt my profitability. It didn't make a damn bit of difference because at the end of the day, at the very end of the day, the parent wanted the very best care for their child. It makes sense. If you're a parent, it makes so much sense. This is not a pair of shoes that you're buying online for your child. It is a contact lens that is reshaping your child's cornea, and accuracy and follow-up matter. And communication, in my opinion, matters more. So this is a cartoon that I modified. It says, we're out of business. We have the lowest prices in town. And that's true. And just recently, I was telling Kelly, I was in New York and I was walking my old neighborhood and saw the place that I worked in. I worked at this optical when I was really young, and it changed names. It looked like it changed several times, and it says lowest prices guaranteed. And when I looked inside, it was empty. If you look in that lower right-hand corner, it was empty. You can play the price game, and it may make you busy, but I don't know if it'll make you profitable. And I would venture to say it will make you miserable, because volume, when it comes to specialty care, in my experience, doesn't work. It burns the doctors out. It burns the staff out. I am not burned out. I've been doing this a long time, and you could hear it, you could see it in my voice that I enjoy what I'm doing. So please consider charging the fees that you feel you deserve. So let's give a real life example. This is Teresa. She's 10 years old. She started developing myopia at 6. She's now minus 450. So just stop and think about this. This is not a 450 myope. This is a child who started wearing glasses, needing glasses, when she was 6 years old. And now she's minus 450. So if you just look at this patient as someone that you're going to control their myopia with MiSight or anything else, you're misguided. This is a family that you need to manage to somehow control their myopia. I couldn't get diagnostic lenses. I couldn't get the CRT lenses in her eyes. She was sensitive. There was crying going on. I think the child was crying and the parent was crying. Parents were very nervous. All of the experienced CRT fitters and Ortho-K fitters listen to me know this happens a lot. But I want the inexperienced, that new practitioner that had the question, that this is part of the course. This is my daily consultation. I just understand. They're asking you to control myopia that has progressed in just 4 years to minus 450. This is a huge task. So after the consultation, we email them. So what do I email them? It's an email that says, it was a pleasure to evaluate Teresa. She will do very well with our program. I've attached 2 papers based on our discussion. So they're papers on whatever the patient had, maybe side effects related to Ortho-K, maybe atrophy, and it doesn't matter. Remember, the demographic interested in managing myopia for their child with Ortho-K asks questions. I provided you with a lot of information, I continue. Please look it over and feel free to email me any questions. So I'm opening up a dialogue. Listen to me. How many health professionals do this? Anyone does this in this day and age that makes themselves accessible? Maybe a doctor who's concierge. So you could see already, if this practitioner is going to your office and maybe to your colleague's office, you, in order to compete with me, you have to give the patient and the parent time. So here's the response. Thank you for providing all the information. I read online there are 2 types of FDA-approved OK lenses. You guys know this, CRT and VST. Which is better? Thank you in advance. Like I didn't know this, right? They're telling me one's from Paragon, one's from... So this is time, guys. So if you're busy just doing it, you're not going to respond, or you're not going to respond promptly. And if you don't respond promptly, then you haven't addressed the subconscious need of the demographic who's interested in CRT as a device to control myopia. You'll fit lenses, but you won't flourish. So they continue. See, it doesn't end. They have questions. They're very curious. They're very educated oftentimes. They're very nervous. It seems to me that one periodical showed that CRT is effective in correcting myopia. However, the conclusion that it slows myopia progression is less obvious. Is there any new information? So not only they're reading them. They are reading them. So now, I would say 90% of your colleagues who are doing cornea reshaping, CRT, Ortho-K, at this point are bowing out. And they have chosen being busy over spending time. Because when I am done answering this family's questions, I have created a raving fan. And they will go on social media or their church group or whatever group they're a part of and say, this doctor, this office is different. And that's how I grew a practice the size that I have, offering corneal reshaping. More questions. Saying this is Teresa's mom or Teresa's dad now. He jumps in. Thank you again for answering all my questions. The price quoted for Teresa was X. We weren't expecting it to be that much. Is it negotiable? A friend mentioned CRT lens for his son. Is this the lens you're using? So you could see, the more you grow, you need perseverance. These are all milestones. These are hurdles I had to overcome. All these emails, all these questions. If I don't respond to this dad immediately, if I don't respond with some valid reasons why my office is different, that it's not just the CRT lens. That's the lens. It's the doctor fitting the CRT. It's more than just CRT. It's how much time your child is on screens. Remember, I have it down. Your child is on a screen all day. They don't go out, sometimes on the weekend. No doctor has the time. So you see what a critical non-essential is? The time to take. So they are hoping it's negotiable. The answer is no. You have to make a decision now, parent. Do you want a doctor who gives you the time to answer all your questions? Or do you want a doctor who just fits your child's eye with the lens? That's up to you. It's not up to me. I've done the best I can to explain to you, to show you, to demonstrate to you, I am the best practitioner for your child. And I educate them, and I'm not affiliated with Kate Gifford. I don't know her. I certainly use her websites. Her husband was very nice to allow me to use their myopia profile site in my reports. She's a clinical optometrist, researcher, educator. She's amazing and owns a specialty optometry practice in Australia. I have no vested interest, but I'm telling you, her site's amazing. She educates us. She educates family. I don't know families who are interested in myopia control. I don't know where they find time to do it. But if you say to me, Nick, what's included in your report is a lot of the information in myopiaprofile.com. I also use that information to help educate parents. So that is really a strong tip. And that's how I come up with these customized reports. And Paragon helped me with this graph on the lower left. I remember asking a consultant, I said, are there stats on how the average eyeglass wearer progresses if they're 6 years old? And what is the projection if they wear glasses when they're like 16? And there are, and they help me out. So I just write a report. The report says it was a pleasure, same thing, and give the history. The mother is -8 and had laser vision correction in this example. There, you know, Teresa's developing myopia. I trialed corner reshaping lenses on it. It's just a review. People ask me, what do you put in the report? I put in the report all the critical non-essentials, the history, my objective data. Today we put the A scans in. I put some graphs that I may get from Myopia Profile, the Brian Vision Institute, Brian Holden Institute. So all these things I've gathered, educating the parent so they know if they do go to my colleagues that it's going to be a different care. I'm not saying better care, just different. So Kelly, I talked a lot about the consultation. Are there any questions, any confusion up to this point?
Well, I think you just answered one of them. One of them was actually about the report. Someone had asked, I write a report for my vision therapy patients. Is the report that you send to parents after their myopia evaluation similar? And just from your last slide, I think the answer is yes, but maybe you can elaborate on that a little bit more.
I'd like to, because that practitioner is understanding what's going on here. When we write reports, it's usually to the referring doctor, and the parent gets a copy, and we explain it. My report goes to the parent. It could go to the pediatrician, but I was inundating them with that. But it goes to the parent because the parent is the one who's going to explain the therapy to their spouse, to their pediatrician, to their friend, to the friend's teacher, to the piano teacher. This is how my practice grew. So Kelly, that was an excellent question. I got the idea from my vision therapy doctor, Dr. Tan, and even when I was trained as a resident, we always wrote reports, but it was to a different demographic. So that was excellent clarification. I write the report for the parent, so they become raving fans, so they can articulate exactly how my care is different from everybody else's. So scheduling is the second tip. So once they're in, my deception was once they sign up for my program, I'm done. This is great. They signed up. No, the party just begins. And if you drop the ball when you're scheduling them, they will not refer friends and family to your office. So the next two is, how do I schedule an application removal class? What do we do in it? And the follow-up visits. The application and removal class is critical. It's an inflection point. When I talk about important times in your practice, in managing your patient with myopia, the application removal class is where there's a lot of stress. The parent stress. They spend all this money, whether they spend $500 or $5,000, it's a lot of money. It's their child's eyes. The kid is stressed beyond belief. My staff is stressed. And this is the point where there's buyer remorse, where some friction occurs, some kind of resistance, and all of a sudden everybody says, this kid can't wear them, I want my money back. This is really a critical time. So to combat this, I use one of these videos that, again, Paragon did so professionally. I send it to every child before their application removal class. And we send them some other videos, but it's a cartoon. I say, as homework, I'd like Teresa to watch this short cartoon that gives her some background on what she will be wearing the day. She doesn't have to study it. She will not be learning to put them in, but she'll put them in and out. Or sometimes we give this video before the actual INR class. So sometimes, depending on how the pre-conference goes, it's before the INR or insertion and removal class, or sometimes before the consultation, but this is a professional video that we show. So what can happen during the application removal class? I'll tell you what can happen. Child starts crying. I can't see. I can't do this. It hurts. Parent, I want my money back. This would happen when I started several times a year. I don't know if it was 3 times. It felt like 23 times a year. Now it happens 0 because of the systems that I created to avoid this. So as long as you know, once your parent enrolls in your system, that this is not enough. You need to orchestrate their follow-up visits. So what do? We tell the child that they're going to get an Amazon gift card worth $30 that they can use in any way they want. So I say, have you ever heard of Amazon? And Teresa just smiles at me. I said, you're going to get a gift card. You can order anything you want. So I would start looking right now. In order for you to get that card, you're going to have to put the lenses in and out by yourself 3 times. So they smile. But we're going to help you. We may give them lubricating drops to practice with before their INR. We may send them videos of how to properly instill lubricating drops in their eyes beforehand, because we know the more they practice with lubricating drops, the less stress there will be when they actually come in for their class. We control nervous parents. The pandemic has helped us with this. We don't want a crowded room, so we now ask parents to stay outside in the car or empty reception area until the child does it twice, because there was too much tension. The parent would be in there videotaping or saying, come on, you could do it, or let me do it, and the tech would get stressed. So now the child has to do it 3 times to pass their class. The parent is out front 2 of the 3 times. So the parent may go out there and stay for an hour. And sometimes I'll go out there like we're delivering a baby, and I'll say, things are going really good in there. She did it once. Oh, Dr. D, how she did it once, and she's scared. There's no tears yet, but I'm right on it, and we're there. So you could see I am addressing the demographics concerns before they voice them. We allot an hour plus, an hour and 20 minutes for this class. Not only do we give the Amazon gift card, we give snacks. If they have a sibling, we give the sibling snacks. And again, we manage the parent by having them wait outside. And now, nobody, I could literally say no one has asked for a refund if they got to the application removal class, because I pre-framed them. If they're really that bad, I didn't recommend CRT. Maybe I recommended soft lens. Maybe I recommended atropine. But you could see that consult has helped me in so many different ways. All right. So Kelly, before I go to follow-up visits, do you have any questions? Did we get any questions on the insertion or application removal class?
We didn't have a question about application and removal, but something did come in about fitting sets. Do
Yeah.
you use diagnostic fitting sets? If so, how are you using them? I think people are interested in balancing potentially using fitting sets and empirical fitting. So what's your opinion on that?
Yeah, that's a great question. I want you to know I fit just about every Ortho-K, or have fit every Ortho-K design out there. And some practitioners use this lens and that lens. I have one basic fitting set that I use 95% of the time, and that's either a CRT or dual axis. So why? It may or may not be the best lens in there, but it's a great company, because I put the lens in for 2 separate reasons, and I tell this to the parent. Number one, I want to see the child's reaction. So I feel, and there's some successful practitioners say, I don't do this, that's fine. I want to see the child's reaction. I want to see the parent's reaction, because that's going to determine our fees. I'll still fit them, but I'll just know it's going to take me more time. The other one is I want to see how well the lens fits. And remember I said early on that I would spend upwards of hours. I think it was 3 hours, I'm embarrassed to say, in 2002, when I was fitting my first CRT lens. It was just like my first refraction. When I first learned to refract, I probably spent over an hour or 2 refracting a patient that now takes me minutes. I don't even know what I was doing for hours. Same thing with CRT. I've fit CRT for so long. that it takes me minutes to properly fit it. If the diagnostic lens is too small, too tight, too loose, I'll know right away, do I need a dual axis? Do I need a spherical? And I change the lens right in the chair. So right away, it has saved me chair costs. I also order all my lenses to warranted. This is not an option I have with many companies. So I'll say, look, maybe I won't get 90% correction. Maybe I'll have to tighten up the landing zone. But you know what? I'm going to start here, and then I have 2 more tries to do it. So the pressure of me of getting that fit perfect is no longer my focus. My focus is making sure that the child is safe and the parent knows that my office is the best for their practice. So that was a great question. Yes, I use diagnostic lenses with every consult, unless the child doesn't let us put it in. Like Teresa, you saw, she was nervous. She was very sensitive. I think we only got 1 of the lenses in. And you know that's going to be, so even if Teresa was -1, her level will be much higher than someone where we put them in and it seemed like a very easy transition because it requires more time. Does that answer your question, Kelly, or the viewer's question?
Yeah, beautiful. Thank you.
Okay, great. All right, and this is the other thing for follow-up visits. Again, your work has only begun. Remember, Kelly asked me, well, how do you grow your practice? Do you send letters to pediatricians or maybe schools? No, I market right in my exam room. Who does it better than me? So I allow time for questions. Now, this sounds so freaking simple, right? That's all I talk about. But answer this question. Do you have time to spend 20 minutes in between patients to talk about screen time, to answer questions about the fit or side effects? I read online that some child had COVID in their eye. Is this possible? Or had an ulcer from wearing an OK lens? I have the time to do it. So I see Ortho-K or CRT patients 5 days a week. All 3 of us, Dr. Lee, Dr. Noah, and myself, we all see patients. Why did we get so busy? We dropped insurance plans. We made the difficult decisions. We dropped primary care exams. You heard, I don't sell soft contact lenses in my office. I haven't for years. You know how scary that was? You know how scary it was to drop vision plans and for me to stop doing primary care that I really enjoy? Because that's money in the bank, right? If I do primary, I know exactly what to expect, but that gave me the lifestyle I wanted. I want respect for my patients. I want to help my patients uniquely. I want to be reimbursed for helping parents or patients uniquely. And CRT has allowed me to do so. So sometimes the father's in, oftentimes I've learned, I've got an email. Every patient gets an email. And about 20% of the time they said, Dr. D, I have a question. Even though I spent 20+ minutes, it wasn't the fit. Remember, I've been doing this a long time. I persevered. Let me tell you something, guys. It's difficult to master reading topographies and getting good at fitting. There's no free lunch here. Don't be deceived that it's easy. If it was easy, everybody would do it and it would be meaningless. It's tough. That's why I started this talk off with perseverance. But the good news is if you persevere, if you get good at this niche, you'll be rewarded with raving fans. So we scheduled next day, 1 week, 1 month. This is normally what's done, and we see them every 3 months. And this is where your profitability is going to go down, even though your gross will go up. Because if you're doing these critical non-essentials that I discussed, for example, spending time to talk about outdoor, spending time about limiting screen time, spending time to talk about side effects or answering the questions, giving snacks, giving Amazon gift cards, but you're not being reimbursed for that time. You'll be busier because you're doing the critical non-essentials, but your profitability will go down. So it's one or the other. You charge what you feel good about charging. This is not something you can price compare. When patients will ask you, well, that other doctor, they fit the same lens. You just need to spend the time. Why is your office different than your colleague who also does orthokeratology? If you don't, the common denominator is pricing, and you can't win with that. This I get on follow-ups. I get them on follow-up emails. Children now keep their visual acuity results at home using some iPhone app or an eye chart they printed, and they're so proud of it, where they'll email me their visual acuity sometimes in the morning, sometimes at night, sometimes monocular, sometimes binocular. Now, if you don't show perseverance now, you certainly will give up, because this is taxing. Because we know, this is not a contact lens fit, but the parent doesn't know, the child doesn't know. This takes time. You may have to pick up the phone and call. I'll do virtual meetings when 20 minutes are not enough time, because I've learned if I take the time to address this nervous parent's questions in detail, honestly, accurately, they will know I'm not just pushing them aside. They will know, yes, he is the best doctor for my child. So you can't have it both ways, guys. You have to decide, am I going to slowly but steadily change my practice where I make the time me available? You remember we work 3 days a week seeing patients. The other 3, I may be devising systems, so I'm not the one answering these emails. But I'll tell you one thing, they all get answered with expediency. Why? Because the parent who's interested in myopia management as a form of correction for their child expects it. All right, so let's give some real life examples. Teresa's been a patient for mine a long time. She's been a patient of mine. Hey, Dr. D, Teresa woke up at midnight with eye pain. She has been hesitant and skips most nights. I am concerned about the situation. I would like to bring her in ASAP. I look forward to hearing from you. I get this all the time. They get lint between the lens, and you would think the world is falling. And if I treat it just haphazardly, casually, no, I'd lose out. Look at my response right away. If I don't do this, my front desk does this, because I've realized all the emails have to come into a central location, which is my front desk. Since Teresa is experiencing fear, I like to examine her ASAP. So you could see these are terms that my staff and I have been trained to use because they want expediency. I've copied my staff. We'll get Teresa in ASAP. Another one. I will give her a note for school. Why do you say that? Because every parent has sent their kid to school, pain or no. Every parent doesn't want to take their child out of school because they're going to lose work or their child's going to lose school. So I've been proactive to give them a note, and I thank them for this excellent update. Instead of saying, shoot, take it easy. It happens. She's new. So you could see how I've taken a situation that would turn the stomach of most practitioners and just made it part of my system. And this is the email after I saw Teresa. I think it's that night. Dear Dr. D, thank you so much for spending time with Teresa this afternoon. She put on the lens at 9 p.m. tonight. I referred my friend. They will email your staff for an appointment. Kind regards. Now you're saying, come on, Nick, come on. The answer is yes, but it wasn't just me responding to the email expediently. It was expediency. It was the time I took for my tech to give her a review INR, to maybe stop ClearCare and try Unique pH, speak to the parent, have my tech work with them, and then email them afterwards. Email, they're referring a friend by email because they have my email. They have my portal, but they have my email. There's nothing breaks HIPAA when someone refers a patient using my email. They have it. So you could see that I've earned this referral. And this is how I've built that practice that videotape that you saw early on of these patients that are kind of my network. What is it called? Raven fans, right? I think it's called a tribe, right? It just escapes me. Who's Seth Godin? Calls it a tribe. The past 20 years, we've had that. So is this marketing? or is just good care? That's the question. I say it's great care. This is a testimonial. Teresa's mom wrote for me after 12 years. I'll tell you, it's no easy customer. Teresa has been cared by Dr. D for 12 years. She started to wear eyeglasses in the first grade, remember? We recommended Dr. D to many friends. He is so different from normal doctors who give patients a few minutes per visit. Dr. D communicates via email and by phone. I wish I wrote this letter sooner, Teresa's mom. So, did any of this hard, guys? No, but it's not easy because you have to make hard decisions. Am I going to be a practice based on volume, or am I going to be a practice based on quality patients, qualified patients who come to me because I'm worthy of their child's treatment? The goal is to have all CRT patients refer qualified candidates to your practice. That's the goal. How you do it, you could do it in your unique way, but price will never win, and just being a great CRT fitter probably will not. I'm not sure, because I am not a great fitter, but it will. That should be your goal. And lastly, a favor from you, because I've given you my all in this talk. I've given you not only advice, I've given you my passion. And remember, I'm a clinician just like you. I don't do this for a living. I do private practice for a living because I enjoy it. The one favor I ask from you is please view my TED Talk on YouTube. I don't get any revenue from this. But what happens is the more views, the more it comes up on people's feeds. And if you comment on it, which I really would like you to do, that improves all of us, because then anybody interested in TEDx talks, this will look as a popular talk and we get the word out. Again, I have no personal interest whether it has 10 views or 110 views. So I thank you very much. I really do hope that you take my advice and my lectures not in vain, and you make some of the changes that you feel will change your practice. Thank you.
Fantastic. Thank you. Well,
Great.
with that, I would like to thank everyone for logging in this evening in order to learn more about how you can maximize myopia management in your own practice. Dr. D, thank you so much. We could not do this without you. I think the best resource of all is just learning from our colleagues. So thank you so much for your time and your
You're
insights.
welcome.
And honestly, just your passion towards myopia management. I think, sometimes we can feel tired or run down in practice, but listening to how passionate you are and how well you care for your patients is very re-energizing. So thank you on behalf of
Great. You're
everyone.
welcome. And one last point, Kelly. I'm tired. I don't have great days every day. I feel like all of you out there sometimes depleted, but that's why perseverance comes in. And this is a great subspecialty that has certainly fulfilled my lifestyle, and I'm sure it will fulfill yours. So thank you for inviting me.
Thank you. And everyone can find resources on the next slide in terms of what you can utilize in your practice for your patients from CooperVision Specialty Eye Care. Thank you, everyone, and have a great night.
Thank you.